présentation des
Laureates for this observatory, and we're going to concentrate on one disease, which is trachoma, when a bacteria enters the eye, and it can be responsible for blindness. There are millions of people suffering from trachoma, but this is a curable disease. Now, for it to be cured, it needs to be diagnosed very early on, and also there needs to be a very close-knit follow-up. So Sightsavers has developed a project in Guinea-Conakry, but this project is being disseminated to other countries. Now, Farrah Bartlett is the director for this program. So you're here, you're not in Africa, and you live in France, right? Yes, I do live in France, in the Gers region, not very far away from Toulouse. A very nice region indeed. So, Ms. Bartlett, you're the director of this program, and we're going to discover this project with a short video.
So trachoma programs operate in incredibly remote environments, and also once we've given surgery for TT, it's required that we do multiple follow-up visits with the patients to make sure that the eyes are healing properly. So these factors combined create a pretty massive data challenge for our programs. So in response, we built the TT tracker, which is helping improve patient care and also data management and use. So the TT tracker is being used in Nigeria, Benin, and Guinea, with Senegal soon to follow. So far, the teams have captured and managed over 22,000 TT patients in the system. We've trained over 150 workers to be able to collect the data, and we've trained over 30 supervisors and administrators to be able to access and analyze and use that data. So countries are able to use the data to track surgical outcomes and plan follow-up activities. It's also a massive benefit to them to be able to have all their data in one place, so they're able to pull reports as needed, including a final report that will be submitted to the WHO in their country's dossier for elimination. We're hugely excited to be able to scale up use of the TT tracker into new locations, so countries where Sightsavers doesn't have programming but where TT activities are ongoing and where they could really benefit from use of the TT tracker.
So TT Tracker is the laureate for 2020. We can say bravo to this project. So you do insist on the two steps for the treatment. There's the surgery first, but then follow-up is very important. I'm going to answer in English because it will be easier for me.
Yes, it's true. So the international guidelines say that after a surgery, we have to do follow-ups at the 7 to 14 day period in a 3 to 6 month period. So that sounds easy, but it really isn't, because the follow-up visits happen in a different location than where the surgeries happen, and they also happen by a different person. So that makes it really important to be able to have all the information on one phone or tablet for them to be able to find the patients who need the follow-ups, where they are and when they need the follow-ups. And also that whoever's doing the follow-up check has all of the information, that full patient record, so they're able to give the best care and advice possible to that patient during that follow-up check. So.
And what we see as well, your system is not so much about curing the disease. It doesn't measure, it doesn't do anything specific, but you're collecting data. So what are the data that you collect and what do you do with them?
So yeah, the data we collect, it's based off of standardized international trachoma forms, so that makes it easy to scale up across multiple locations because all the forms in every country are the same in the trachoma programs. So there's registration, there's evaluation, there's surgery, and then there's all the different follow-up forms. And so those are used, like I said, by the teams. They're able to see those patient records, which are all connected later, so they're on the phone. And then they move up. You can see supervisors are able to watch program performance and make changes, clean the data as it's coming in. And then, of course, on step up from that, they've got the benefit of having a centralized place where all the data are sitting. It's owned by the Ministry of Health. It's managed by the Ministry of Health. So there's one source for data. And that goes for creating reports of any kind, but it also goes towards the dossier that we talked about in the video. So to prove that the country has eliminated trachoma as a public health problem, you have to fill it in this dossier. And part of it is showing that prevalence is low enough in all the different districts, but another part is proving that you've done certain activities in certain locations. So this Genity tracker and having all that data in one place helps them immensely as they get.
So there's a double benefit, right? There's a benefit for the patient because we're sure that they're going to benefit from the right follow-up and they're going to be cured from their trachoma. But there's also a benefit in terms of health policies for each country with the objective of eliminating the disease.
Oui, éliminer. Oui, exactement. Oui.
So how do you coordinate? Because I understand that you operate in different countries. So are there different policies or do you have a joint policy?
A little bit of both, I would say. Sightsavers manages this tool, we built it, and our job is to make sure that it functions properly and that people in the countries are using it to the best of their ability. But we do very much see it as a national tool, so the ministries of health are highly involved in making sure that it's rolled out properly and used properly, and again, they own the data. So I think, yeah, a little bit of both.
In the video and also in the pictures that are currently on the screen, you also go and monitor people in a remote area. The fact that it's a 100% digital tool, isn't it a hurdle? Isn't there a cultural hurdle here?
I wouldn't say cultural necessarily, but there are definitely different rules to follow when you're trying to collect data or use applications in such remote locations. So there's like the hardware side of it and then the software side of it. So the hardware side of it, it's all obvious stuff, but sometimes we don't think about it. You have to make sure the phones or the tablets or whatever devices you're using can, withstand lots of dust and lots of sun and many hours without being charged and all those basic things that are easy to forget. And then on the software side, you have to make sure that any application you're building is accessible offline so that it can be used and data can be uploaded even if there's no connection. And also, I guess, just make sure that this is true for any technology, but they're really building for the user. So if you're building something in a very remote location where people might not have a lot of access otherwise to technology, you need to make it so it's very easy for them to use so they keep engaging. And
very last question. Maybe if we want to step back and have another view in the countries of the South, I know that your association also manages other tools and applications. So what is your take on those questions that we contended with this morning? Why do you think countries of the South have more appetite for those tools, while countries in the North do not really develop such tools, do not harvest data in the same way? We're under the impression that there's quite a gap. So you have a more worldwide view. What's your point of view?
Yeah, that's a difficult question, actually.
C'est pour ça que je la pose.
Yeah, exactly. But I think it might be a little bit of a sensitive one, too. I think that a lot of countries in the North, populations are more skeptical of how data is going to be used, potentially, so they're less likely to maybe engage with and give data to input data into these applications, despite the fact that there are regulations in place. And of course, there are regulations in place in the southern countries as well. But I think some of it is around thinking around that. That would be my
Ouais, c'est le logiciel des populations, mais également le logiciel, j'ai envie de dire, des systèmes sanitaires qui peuvent aussi être sceptiques. Est-ce que c'est plus facile de faire changer le logiciel des systèmes sanitaires en Afrique, de le faire évoluer plutôt qu'en Europe, à votre avis?
J'ai pas compris exactement.
Vous nous dites que des populations peuvent être sceptiques en Europe vis-à-vis de ces outils digitaux. Bien sûr, il y a les populations, les patients, mais il y a aussi le système sanitaire, les médecins, les soignants, les hôpitaux, qui peuvent être également très sceptiques vis-à-vis de l'utilité de ces outils. Est-ce que c'est plus facile d'intervenir auprès de médecins africains, qui sont plus ouverts, que des médecins européens, par exemple?
I think they are more open, especially if you have an application that can help them with their jobs in the end. It's not, because we can't have the focus of just pulling data from programs. We have to have the focus, and people were talking earlier too, of making sure that there's feedback back to the people who are collecting the data and who are doing the work. So at least in our experience, we've found that as long as we have that feedback loop, that people, doctors and teams at the lower levels are very interested in using the application because they're getting something from it as well, which makes sense. It's why any of us use technology. So.
Toujours, quel est le bénéfice?
Yeah, the question is always, again, to have a benefit for the end user. Well, thank you very much, Sarah. I'm sure that there will be many questions at the end of this roundtable. Now, we stay on the African continent, but we go to the DRC, and we're going to see a disease which assists in the management of sickle cell disease. So this is a disease which has for a long time been neglected by the PFAB Foundation, has been a major player in this area for years and years. We're going to listen to Arnold Wogbo. He's a founder and director of Genity Sarlu. So how is the weather like in the DRC? Well, it's beautiful sunshine. We have a good weather today in the Democratic Republic of Congo. So you created a startup and you developed an application to help with the daily life of people with sickle cell disease. The app is called Anemiapp. So it's a lifelong disease which affects the red blood cells, and there's a lack of oxygenation. It is inherited, an inherited disease, and it affects quite a few millions of people worldwide. So Arnold Wogbo is the general director of Genity, a startup. Anemiapp is an app which helps with the management of sickle cell disease. 50,000 children are born with sickle cell disease in the DRC. So thanks to this app, the patient receive information to avoid relapses. So the advices, for example, are to maintain a high level of hydration. Kinshasa has 12 million inhabitants. It's a very large capital city. And the application provides a mapping of the different healthcare providers. So you can identify the places where you can be treated, where you can receive blood transfusions or be delivered with drugs. Today, Anemiapp is supported by the Ministry of Health in the DRC, and it is used by a wealth of healthcare professionals. The objective is to have 100,000 users per year. Thanks to this award, we'll be able to maintain the app, to communicate more, and also to rent new offices.
Anemiapp,
round of applause, laureate for 2020 for this South eHealth Observatory. Arnold Wogbo, so before you created the startup, you worked in an NGO, and this is where you first discovered the disease, and you realized that the population didn't have enough information on this disease. So what was it that you wanted to provide in terms of access to information? What was your objective? So, as you mentioned, people here know the disease, but in a very superficial way. So they would make a confusion between the blood type and the blood group as well, and they were not sure how the disease was transmitted. Now, thanks to this application, well, you know that in the DRC almost everybody has a smartphone or a mobile phone, and so we thought that it was the best channel through which we could provide information in terms of prevention and also information. And this is why we came up with that. So this app is used by the wider public, but also by healthcare professionals, because you realized that they were also lacking information. And so you have a dedicated access for healthcare professionals. Why is that? Answer. You know, there are very few experts in sickle cell disease in our country. And so we needed to create a network of those healthcare professionals and healthcare providers. So, for example, let's take a general practitioner. They do not have many information on sickle cell disease, and they have a patient coming in their practice. So they can get in direct contact with an expert, and they're going to get recommendations on treatment. So this is very important. More often than not, we want to communicate with the general population, but it is very important also to underline that general practitioners also need information. Not all of them know what is the perfect or the best treatment. They do not know where you can locate the experts or the drugs, so you create a connection in between those professionals, right? Answer, yes. And so with the support of the Health Ministry, in the framework of a national program of fight against sickle cell disease, we could receive a list of all doctors specialized in sickle cell disease. So we work with that list of experts and we create a network. So once the network is created, we provide access to GPs. And as I said, those non-experts doctors can get information on treatment, on follow-up, etc. So this is very interesting. So, of course, when you create an application, there's a trial and error phase, right? And are there some learnings that you'd like to share? I know that you started developing this on smartphones, and maybe it wasn't the right system to begin with. Could you please tell us more about your learning curve? Well, we realized that not all citizens in the DRC have an access to the internet. So the application was initially created on Play Store, but if the patient or the GP do not have an internet access, then they cannot have access to our application, and that's a shame. So we thought that instead of having a web-based solution, we would have a USSD app, which can also work offline. So even if you do not have a smartphone with a regular mobile phone, the user can access all information pertaining to treatment, screening, etc. So Arnold, we see that one of the main challenges in e-health is the question of data collection. So with your application, are you collecting data? Are you harvesting data? What type of data? And what do you do with them? Answer. So we collect data for statistical purposes with the Health Ministry. Now the figures that we have are just rough estimates. We say that about 50,000 children are born in the DRC every year with sickle cell disease, but this is a rough estimate which dates back many years ago. So thanks to the application, we have more accurate data on sickle cell disease in a specific region, and so this is a work that is being carried out with the Ministry of Health of our country. Last question on this award and on this application. So you said one of the challenges is to develop this application, increase the user base. You would like to have as many as 100,000 users. How are you going to do that? Answer. As I said, We work with the Ministry of Health, and we are going to work on the dissemination of this application with a wider population, so that the wider public is informed that this application exists. So we hope to reach that threshold of 100,000 users in the near future. I do see that behind you there are many people. Are you talking from the AUF campus? Yes, that's right. I'm sitting here with students. They came here to support me, so I'm not by myself. Well, that's great. That's great. That's great to see those rooms which are full. I know this is a difficult time, you know, in regards with the crisis. So congratulations and bravo to people in Kinshasa. Congratulations. I'm sure that there will be many questions for you on the chat. I'm going to read one of them. Dominic in France says, well, congratulations. Thank you for sharing this experience. Thank you so much. Thank you for this message. Laure says, well, hello from Dakar. I'm delighted to be able to follow this conference. Dakar is one of the countries where we had a very good mitigation mechanism thanks to our community. Now, do not hesitate to ask questions, but in the meantime, we're going to have a presentation of the next project in Guinea. Professor Fode Abass Cissé is a neurologist at the University Hospital of Conakry. Can you hear us properly, Professor Cissé?
Allô, allô, est-ce que l'on a
Hello, do we have our professor connected or no? He's not connected. Okay, well, maybe we can ask, maybe the US, because we have Farrah. You are in the US, you work a lot there. What time is it there? Are you connected?
Yes, I'm connected. Thank you very much. Can you hear me?
C'est parfait.
Perfect. Loud and clear.
Excellent. Yeah. So excellent. So it's about 8 a.m. where I am now, and I work closely with Professor Cissé and the whole team for the Guinea Epilepsy Project, and we're very grateful to be receiving this honor.
Ah, merci beaucoup.
Okay, it's 8 o'clock in the morning. You're an early riser because you are living next to Boston. So you are awarded, both of you. We hope that Mr. Abass Cissé will join us. So it's a little hat that was, in fact, will create ECG from a distance, so to detect the first sign of epilepsy. So this is a tool that will be a first worldwide. The Pierre Fabre Foundation is supporting this project. So of course your wish is to go one step further. The idea is to connect it to AI computers so that they could read directly the recordings so that the doctors can screen the first signs and also then refer the patients to neurologists. So of course, we also will continue supporting that second phase of the project. Let's discover a little video.
Epilepsy is hugely important to Guinea, like it is around the world. One is premature birth. Another is the sequelae of different infections of the brain can lead to lasting consequences. Finally, we know that there is an increased risk of head trauma.
So of course this helps screen the patients.
next step is to use AI, or artificial intelligence, and that will help us understand the vast amount of data we're able to collect from EEGs and potentially have point-of-care interpretations. Data from the electrode cap is transmitted to the app, which is on the tablet or the smartphone. We believe artificial intelligence is really the way forward for using EEG at the point of care and locations without experts.
Qu'on puisse former les gens à son utilisation et aussi qu'on puisse à court terme coordonner l'interprétation de ces examens effectués parce que le but c'est de faire le diagnostic et de prendre en charge ces patients.
We hope to use artificial intelligence and apply it to EEG in low resource settings, just like in the Guinea Epilepsy Project.
So this is Guinea. We could have a warm applause for this project. So we are going to now have Farrah. So we speak of Guinea and US, but it's a more global project, worldwide project, especially in the second phase, because the idea is to fuel computers to develop the algorithm. And then there are other universities that want to work with you.
That's absolutely correct. So EEG is an older technology, but there have been two challenges. The first is the technology to capture the data, which we have worked on in phase one. So we are trying to bring a very expensive piece of equipment to something that is mobile. So we've been able to accomplish that to some degree. The second part, which is equally as difficult, is to take the data of the brain waves on the app and actually make it usable at the point of care. So currently, you need a neurologist who reads the output, and that can take several minutes. And often there's a long delay between collecting the data and interpreting the data, because the data right now requires a neurologist, which takes approximately 10 years of training. So what we want is to use computers to automatically interpret the data based on trained algorithms. And we are working very closely with universities. I have collaborators at Harvard, where I work, also collaborators at the Danish Technical University in Copenhagen, and working very closely with Guinea and our African colleagues. But their epilepsy affects 1% to 2% of the entire population globally. So we want to be able to use the Guinea Epilepsy Project as a demonstration of what can be done, hopefully throughout Africa and other countries, including in high-income countries, because this challenge is everywhere.
Farrah, I think what you're saying, as Derek was saying, he said that the challenge is to really work together, have a community of projects, and we can see that this project is a token of this. So I think on paper, in writing, it seems simple. We just are going to train the computer and read the scores, and then we're going to give them figures. But in truth, it is not. It's very, very tough to do.
That's correct. So this is, I think, a really good way that we've been able to collaborate. So in the US, we have thousands of EEGs we've performed on epilepsy patients, and we can use these data to inform our model. But one of the issues is making sure that we're both sensitive and specific. So we want to be able to capture changes, but not capture changes that are not important. So this is going to take multiple iterations of the training. It's going to take engineers, computer scientists, software scientists, as well as the clinicians. We think it's very important because Guinea has only 5 neurologists, and there are 12.5 million people in Guinea. So we know neurologists, that person can't read all the EEGs for the many people with epilepsy. So the computer has to be able to help. We just have to work with it.
So this means that you need to give all this data to fuel and really get that. So where do you find this data, mass data and high quality data?
Right now, we are starting with the data that we have from Boston and from Denmark. We're using known diagnoses of epilepsy with standard EEG machines. And then the next step is to take our mobile EEG data from phase 1, at which time we collected more than 500 EEGs from the mobile app in Guinea. And then we will use those data to train it again. And the hope is that with several repeat efforts of this process, that we'll be able to at least understand quality of EEG and what we call spike detection. So we won't be able to provide a full read immediately, but we're going to take one bite at a time, little piece by little piece. And I think with concerted efforts, we will gradually get there.
Thank you so much. We have now the connection with Professor Cissé. Professor, congratulations for this wonderful award for the observatory. Now, is it frustrating or rather frightening to say tomorrow a computer will be able to do my job? Exactly the same job as a doctor, and could even be a better doctor? No, I don't think so. I think the idea is to really work with computers and not replace one another. I think that the ECG, and this is a gold standard, a diagnosis to confirm, but you know, the doctor will confirm the diagnosis. This is not going to be done by a computer. In fact, has to look at the epilepsy episode, and then this is going to confirm this by an ECG. So this is what we call a clinical confirmation, but in no case it will replace a diagnosis. So it's good to have innovation, something quick, and maybe having a good, I would say, confirmation of epilepsy episodes. Now, Professor, you talked, because you said, okay, it's nice on paper, but in reality, it's not easy to have an algorithm and having high quality data. And in addition, you know, the human touch is not going to replace, you know, if you have 30 different neurologists, they will have interpretations, different ones. And I think the computer has to also learn how to take this into account. Yes, I agree. But as we said, we are trying to stay optimistic. The idea in Africa is to record the activity of the brain. Of course, then there's AI algorithm, but the fact of having already an ECG recording the brain activity, this is already a step forward. Learning how to read ECGs and make it more commonplace. I think that's quite nice, and we will see how AI can even help us further. So when is your deadline? 1 month, 6 months, a year? When will we have this tool? When? Oh, that's a good question. We look, the hat is already here, the little box is here, then there's the tablet with the connection. So I think that's already a good step. Now, the algorithm is more in the hands of engineers, and we will see. Okay, I'll send the question because she's with us.
Farrah, c'est pour quand l'algorithme?
When is it? For tomorrow? 3 months? 6 months? A year?
Dans 6 mois? Dans 1 an maximum?
Right. Well, we wish it was already finished, but the reality is it always takes longer than we expect. And so we know that for the heart, it's relatively straightforward. There are only so many leads. The brain is very complicated. So to answer the question, with the foundation, we are planning to make significant progress in the next 12 months. But, you know, there are a lot of nuances. So we will start with adults, and we will start with quality of EEG and spikes. And then we will make it more complicated after that. But we're hoping in the next year we will show you progress. Maybe this meeting next year we will show you something.
C'est bien.
Thank you so much. Another question, Professor, in Conakry, in Guinea. Now, the support of the foundation Pierre Fabre, is it important for you?
L'Observatoire de la santé est-il important pour vous?
Very important, because this means that we can continue moving forward, having some electrodes on the hat, more material to record the activity of the brain, and also maybe remove the stigma when it comes to epilepsy, because obviously these patients are, we can talk about the disease, we can talk about, so the fact that having more information, in addition to the development of innovation, but the fact of talking about epilepsy means that people understand the difficulties and removes the stigma of these. As Farrah has said, next year maybe we could have the smartphone available for Guinea, and why not for Africa? Well, we cross our fingers, and congratulations to both of you. Warm applause. I think they deserve this. We will have a lot of questions on this project. A very ambitious project from a tech and social point of view. And now we will see a couple of questions. If you have any questions for our three awardees, a lot of questions already on the net. The first one is Professor Cissé. François Charles is asking the question, saying, Professor, it would be amazing to have this in in the Upper Guinea, because epileptic patients are considered as crazy people and they are locked in psychiatric hospitals. Yes, as Charles-François just said, if he knows Guinea, he says that 2/3 of the territory has no neurologist. So if you have a patient who suffers from epilepsy, well, they cannot treat the patient. With the smartphones, we can help that. We can have caregivers. So it's very important to have what we call adapted low-cost diagnosis tools, easy to use in remote areas. So again, as I said, there's a lot of stigma. They are mistreated. Sometimes they are removed from their families. So there's a social cultural consequence. Gradually, we are trying to improve this with free consultations and so on that we organize with Farrah, but there's still much more to do, and we need to have tools to remove the stigma around epilepsy. Another question in the room. So we have comments in the room. And another comment, we always learn a lot from your meetings, so thank you so much. And thank you for these heartwarming messages. Now, Babacar in Senegal is saying that these TT trackers, digital solution, is a good way of tracking indicators and also is a great decision-making tool. So thank you for writing your comments. Then, in Navarre, we have a question. My name is Robert Giraud on sickle disease. I have a question. For him. I think that the application that informs on sickle cell disease, sorry, there's a problem with the sound. Anyhow, I think your application is great. And I have a question on how they use the tools by the patients. Did you think of summing up for the patients in 10 sentences the main symptoms of this disease, and could be shown when the patient goes to see a doctor? Why am I saying this? Because I know a lot of patients are reluctant, they are hesitating because they say, the doctors don't know about the disease. But if you have a little summary of the main description of the condition, then that could be a definite help. Well, we always inform, some patients know well their disease, and so when they are in front of a doctor that don't, what happens? In my app, there is the possibility for the patient to they can have the address and name of a doctor that knows about the disease. And then there's also a kind of forum, dialogue. People share their experience, giving advice. And sometimes this is for the application. Okay, thank you. Any other questions, comments? Questions for our 3 awardees of 2020. So we have another question from the room in Lavore. And again, from internet, don't hesitate to ask a question. Hello, my name is Isabelle from DataCraft. I have a question for Sarah. If I understood well, the data analysis is done by the ministry. Do you also work on how you're going to collect the data? Because, you know.
Yeah, so it is definitely managed by the Ministry of Health, and inside the Ministry of Health, there's always an NTD department, the Neglected Tropical Disease Department, which the Trachoma program sits under. So it's really that team that we help. And so our Sightsavers support team for the TT tracker does have access to that data to be able to help them with data cleaning. So part of our purpose, I think, with the TT tracker is not just to give software, but to also be able to give the necessary support to use it. So we have a team that does biweekly check-ins with the ministry representative, who's the administrator of the system locally, and they go through and look through a data quality dashboard and do all those things. So I think we're just trying to give an extra push to make sure that all of that is happening, even though it's certainly in the hands of the ministries.
Juste en complément de la question.
So, to conclude, locally you have specialists that are capable of analyzing the data, or do you call upon other specialists in Europe, in the US?
We do, when we go into a country with a TT tracker, we have the Ministry of Health choose an administrator. So they're the person who's going to be the lead of the system, and we do the training with them to be able to pull reports, analyze data, and do everything that any of the projects or the program would need them to do. So they're the ones who are managing it in country.
Another question, maybe for Farrah or Sarah, another question. Someone is asking how can you cope with the challenges of data quality? Do you have what we call a mechanism to have a close follow-up?
Well, it's impossible to do anything 100%, but I think some of the things we've touched on lead towards that. So making sure that we do the suivi at the 100%. All we can do is make sure that the information is there and that the programs have a push and the ability to find the patients who need the follow-up, and then make sure that the project is supervised properly. So when that doesn't happen, somebody asks questions, say, why is this follow-up rate low and what's going on here? And that's part of having that supervision and having that dashboard of live data so you can make decisions as things are happening. And then on the data quality question, back to what I was just saying a minute ago, we've got this data quality dashboard, so it flags anything that looks like it should be out of range or that needs to be analyzed further. And so that at least keeps the data clean as it's coming in, because it gets stuck somewhere before it can move into the central database. So.
Another question on TT tracker, more technical question, but at the same time links up with what we said this morning. Is it 100% ownership by the teams, or you had you went to see the GAFA to analyze the data on the cloud? We talked about Microsoft, but why not Amazon? Because they can analyze the data, geolocalization, mass data. These are very much used tools.
We took the road instead of using software systems which already exist and they're relatively low cost and configuring those to our needs. So we've used a few pieces of software that are either open source or low cost compared to something that would come out of Silicon Valley probably. And we've put a lot more importance, I think. I mean, the software is important, the application is important, but we've put a lot more of our focus on the collection of the data, the quality of the data, the use of the data. So those are skills and things that are important with any technology and, patient tracking or any sort of data collection of any kind where we're working.
Another question, still for Arnold Wogbo, the application Anemiapp, is it available in other countries in Africa? Arnold? Okay, we'll see if we can get connected afterwards. We have time for a last question. We will have a question from the Minister of the Health of Burkina. Okay, sorry, Aminia is back with us. So maybe the question from the Minister and... Thank you very much. I would like to firstly thank the organizers for this meeting. And we can really look at the implication, the contribution of the foundation. I don't have a question as such, but I would like to really congratulate from my heart, the fact that you are really showing that it's not just e-health, but it's also the decision makers has to be well directed. And the foundation has shown that we can reduce the mortality rate because of, and thanks to treatment. I'm thinking of sickle cell disease. It's unfortunately, in fact, diagnosed at a late stage, and we cannot cure this. And I also wanted to pinpoint the epilepsy. So a lot of cases that we have, and I'm delighted to see that we have now data that could really help us make the right decision. So thank you and congratulations to all. Thank you from Lavar. Thank you. All this is important. We are going to see if we can ask one last question to Arnold on sickle cell disease. Now, this application, do you think we will have it and see it elsewhere in Africa? Yes, we have started in Congo Democratic Republic, which is the third country that has been affected by sickle cell disease. In Africa, we have 80% of the patients. So that means that we need to expand our project to other African countries. Well, we, of course, are behind you, and we hope that you succeed. Congratulations to all our awardees.